right, so right now we have an audience of former students and alumni and then one person who we don't know. So welcome to our presentation. Do you want to introduce yourself and tell us who you are before we start? No pressure. No pressure.
My name is Rachel Walden. I'm the clinical director at University of Nevada, Reno.
Perfect. Okay. All right. Well, hopefully you'll learn a lot from us, and we have our cheering crowd back here who has lived this experience. So this session is titled Integrating Interprofessional Education into On-Campus Clinical Training. I'm Sharon Glennon and Karen Potash on the end. Karen Helmuth Day, Iona Johnson, and Lisa Geary are co-presenting with me. We are all faculty and staff at Towson University, and we have absolutely no financial or non-financial relationships to this talk to disclose, other than we're employed by the university that we'll be talking about in this presentation. For those of you who don't know, interprofessional education is required by accreditation bodies, and in fact, ASHA's accreditation body is going to start requiring that programs demonstrate how they include interprofessional education in their training programs, and it's also an expectation of the workforce. A lot of people mistakenly think that interprofessional education is just having a guest lecture about what a physical therapist or an occupational therapist does, or maybe doing a group project with someone from another discipline, and that's not what it is at all. This quote by Ernest, which says, "Working in groups is not the same as learning in teams," I think summarizes it all. IPE is experiential learning with patients. It's purposeful, it's collaborative, and it goes beyond healthcare to whole care for the clients and individuals who are involved. This is the Queens College diagram of IPE that I think really conceptualizes things. They talk about early IPE training being exposure, and the examples down there are their own, but just sort of exposing students to IPE through maybe a collaborative practice teaching module that you do, and then moving to the mid-stage where you start to immerse students into IPE. You might have a care workshop where you have students teaming together to do something, and then at the late end, students need to achieve competence in IPE where they're actually working in healthcare teams, learning how to work with people from other disciplines. And one of the things that we tried to do at Towson University is see if we could get students during the on-campus clinical experience towards that point, past the midpoint, into some of the actual IPE experiences where they are actually working side by side with students from other professions before they graduate, not before they graduate, before they go to their off-campus practicums, so that when they start in schools and medical centers, they're already used to working and collaborating with people from other disciplines. And so just a brief history of IPE at Towson University. We had a speech-language hearing center on campus for almost 40 years, and like a number of university clinics, it was in the deep, dark dungeon of one of the oldest buildings on campus and was not very inviting to go into. And then in 2012, we opened up a new building called the Institute for Wellbeing. It's about a mile from campus. And we've incorporated all of the College of Health Professions community outreach programs into this single building. And so the Institute for Wellbeing consists of the Speech and Language Center, which Karen Potash on the end here is the director of. We have an occupational therapy center, which primarily trains our occupational therapy students. The Hearing and Balance Center for audiology, of course. The Husband Center for Adults with Autism crosses disciplines. And then we also have the Wellness Center, which is a fitness center that our exercise science students participate in. And all of these are under one roof. After we moved together in 2012, prior to 2012, we tried to do some interprofessional education programs, we sputtered along, but it was really, really difficult to do. After we all moved together into this one building, we really tried to purposely build interprofessional education programs into our clinical practice. And so just an example of some of the programs that we offer, we have, we call it WISH, Wellness in Stroke and Head Injury, where adults come together twice a week for half a day, and we have, they work out in our fitness gym with the exercise science students, and then with OT and speech, they do a number of activities while they're there. Our Husband Center for Adults with Autism, you can see in the picture of the kitchen down at the bottom, does a lot of initial social skills training, literacy training, work skills training, and again, we have speech and OT combined there a lot. We have a Children's Therapeutics Center, which combines speech and OT. We have a musician wellness program that we do with audiology, speech, and OT, dealing with voice, ergonomics of playing, and then hearing. Numerous social skills groups, numerous sensory motor skills groups, and developmental screenings. Across all of these programs, the primary two disciplines that we're teaming together a lot are occupational therapy and speech language pathology. Other disciplines come in and out a little bit, but those are the two primary players. And what you're going to hear today is us talking a lot about what we had to do to get those two disciplines to play in the sandbox well together. We know that students benefit from IPE when we do some pre and post surveys of students at the beginning of the semester and at the end of the semester as to their ability to communicate with a team, to negotiate responsibilities, to actively listen to all another. We see significant differences in abilities across all of the components that we measure. And so a lot of times when you go to these IPE workshops and conference presentations, everyone talks about doing it and what they're doing, and they make it look so easy. And I can tell you that it totally wasn't. It was years and years and years of getting us to play well and cooperate in this sandbox together. And so my colleagues are going to be talking about some of the issues that we ran into on scheduling, documentation and grading, student abilities and expectations, administration and funding, and building bridges. And so we're going to tell you about the lived challenges that we had trying to make this work, some of the lessons that we learned, and then some of the solutions that we came to from the trenches. And again, it's primarily going to be about the collaboration between speech and OT, and I'm going to turn it over to Karen Day, who's going to start talking about some of our scheduling issues.
Hello. I hope the microphone doesn't pick up my dinner stomach rumble that's happening up here. So I am going to talk about scheduling and what happens when more than one department determines schedules. And I'm going to talk about some challenges that we faced and some solutions that we've come up with. I am part of the Children's Therapeutic Program, so it's speech and OT in a group program. All the children have communication problems, and many of them have challenges related to occupational therapy as well. I've been very fortunate to be part of this program for many years, from starting as a single discipline program with one classroom and then growing, adding OT, and then growing into multiple classrooms. So I've gotten to see the scheduling challenges evolve as the program has evolved. And I think the first level of scheduling issue, and probably considerations for when you're planning a program such as this, is to know the requirements from the credentialing bodies. So ASHA and AOTA have different requirements for their students. And as we know, in ASHA, we have our clock hours, we have our big pot of hours, and more hours is better within a semester. We're trying to reach our total number by the end. AOTA has level 1 internships, level 2 internships. They also have hours attached, but the hours don't necessarily naturally align with the length of a semester. So for my program, my classroom is a 4-day-a-week classroom. I can't have the same OT in there every day of the week, or else they would get way more hours than they need in their level 1 and level 2 placements, and then it would be kind of there would be inequity amongst students. In addition to that, the supervision requirements are different for speech and for OT. So for speech, we know we have set percentages that we need to have for supervision. For OT, they don't necessarily have to have an OT at the placement for a level 1 internship. So that's just a consideration in terms of planning and figuring out what this is going to look like. The next level of challenge and consideration is how our clinical experiences align with our practicum. So it's things that occur more at a facility level. So for us, it's a university. For us, our experiences are aligned directly with a clinical practicum course, and our student numbers are stable, and Karen Potash does the placements very early, and so we know who we're going to have and when we're going to have them. For OT, they're really doing things very differently, and their experiences are linked to academic coursework. So if you're in a PEDS class, then you may get assigned to the children's therapy program. So you're learning the pediatric content concurrently in the OT program. So the numbers vary per semester depending on enrollment. And those clinical placements occur a little bit later, which adds some more challenges with communication and orientation and things like that. This has made us need to change our clinical model from semester to semester, depending on who's available, and I'll talk a little bit more about that in a moment. We follow a model of one-to-one speech clinician to child in our children's therapy program. We have, I'm there 4 days a week, and I have two different groups of students, a Monday, Wednesday speech group and a Tuesday, Thursday graduate student group that's covering the 4 days. For OT, there's a different group of students each day of the week. So Monday there's a group, Tuesday there's a group, Wednesday there's a group, and they remain with us for the semester, but they're only there 1 day a week. So that makes a lot of challenges in communication and making sure that Monday knows what Tuesday's doing, knows what Wednesday's doing, and so forth. We also I'm the constant supervisor across the 4 days. We have two different OT supervisors depending on the day of the week. And our primary OT student might not be available each day, so we've had to be flexible in dealing with those kinds of issues. So I had 3 slides of challenges, and I have 1 slide of solutions. We are continually adding to our solutions list, but really the biggest thing here is flexibility has been the thing that has made us work together the best, and flexibility in terms of timing of meetings, in knowing who's at a meeting at a given day and making sure that the information is relayed to the people that aren't there. Something that's been really important semester to semester is flexibility with the clinical model. So our speech model has remained constant, the one-to-one, but there may be some semesters, depending on who we have available for OT, where we need to do a more consultative model versus a more direct model with the OT service. We also have used level 2 students to bridge the communication gaps between the level 1 students. So we've been flexible in the way we've used the OT students. We've also, in some semesters, and it's happened more in the summer and semesters past, we've had no OT students available. And in those cases, we have used the OT supervisor as the service provider in the room. Our kids still need the service whether we have students available or not. So we have used the OT professionals as the provider. We've also recruited OT students who want to volunteer and get more experience. We've used independent study students. Over the years, we've done a lot of different things to make sure that we have who we need in the classroom. We standardize processes whenever we can, but we're constantly revising and reviewing and changing based on what we have. And the other solution that is really important is just open lines of communication. Open lines for the needs of the staff and the clients and the students, and we communicate in a variety of ways, through email, through shared private drives, through face-to-face meetings when we can, and through relaying of information. So I'm going to turn it over at this point to Lisa Geary to talk about documentation and grading.
Hello. I'm a little bit shorter, so I'm going to move this down. There, I think that's better. All right, I am Lisa Geary, and I'm on faculty at Towson, and I also am a clinical supervisor. So I'm coming to you from the perspective of a supervisor in the children's therapeutic program that Karen was just talking about, and I also have the privilege of supervising in the Hussman Center for Adults with Autism. I run a couple of programs there. So I'm going to be talking to you about documentation and grading challenges across disciplines and across programs. So, and just to let you know, our overarching goals for our interprofessional collaboration is, of course, we are doing this for the benefit of the clients that we serve, but we also have this overarching goal of training our students. And along with that training comes documentation to document client progress and the grading for the students. So in terms of documentation across disciplines, we have our speech language students that do a comprehensive list of documentation each semester. And it's all related to the client needs, and it's aligned with the clinic procedures. They do daily SOAP notes, and they have a comprehensive treatment plan where they establish long-term semester objectives, and then they break it down into short-term objectives. And so then they track their progress on those goals. And at the end of the semester, they're submitting a comprehensive progress report that includes the background, clinical impressions, and then, of course, the final communication status. Occupational therapy follows a similar model, although their documentation isn't as comprehensive typically. And part of that is because of the model that they use. Some of their services are implemented with that consult model. So because of that, they're maybe not addressing specific goals, but they're providing consultative services. But there are a lot of similarities between the two disciplines. Right, so, yeah, I'm sorry, I don't know what you're saying. Anyway, so the challenges that we have identified in terms of IPE documentation is that the OT and speech timelines typically differ. The OT students have a lot of documentation that they are required to complete, and maybe this is what you were trying to get me to say. The OT documentation is aligned with their coursework. The speech documentation is aligned with our clinic work. So because of that, there are certain things that drive what is required. Many of the OT students are completing specific assignments, things like administering certain assessments, and their documentation is related to that specific course assignment. So our SLP students are documenting in terms of clinical experiences as appropriate for the client and for what the practicum requires. In addition to the differences in timelines and the purpose of the documentation, there are also differences just in where we house the documentation. We often separate our final reports by discipline. So it used to be that, they were going home separately, and we've streamlined that a little bit. But even just where we house them in our clinic, we have separate OT files and separate speech files, and we try to copy pertinent information into both charts, but right now they're separate. All right, so grading challenges, and this is back to the point where there are different reasons for the work that our students are doing. For the speech language pathology students, they are completing their clinical practicum on campus, and so their grade is based 100% on the supervisor evaluations. And for our OT students, this grade that they are receiving is incorporated into their coursework. So it's the actual course instructor that is, determining that grade. And the supervisor that is in the room with those OT students does have some input, but ultimately the final grade is determined by the course instructor. And so that has created some challenges as well for a course instructor who is actually not in our programs at all. The grade does not always reflect the skills that are required in a collaborative program as well. And so our grading criteria is separated by a discipline. The OT instructors don't necessarily observe the OT students in their clinical experiences. It's the OT supervisors. So they do the best that they can, but they're not always on the same page in terms of the clinical work that the students are actually doing. All right, so let's get to the solutions. And this is an ongoing process, but we have learned that the biggest solution is communication between the disciplines and also, of course, between clinical supervisors. So in addition to the SLP supervisors and the OT supervisors communicating as much as possible and providing input on both disciplines, the course instructors obviously need to communicate frequently with the clinical supervisors to provide information about how the students are doing. So the more communication we have there, the better. The next area of our solutions are the integration of the discipline. So we are working on systems to better integrate how we combine SLP and OT information, especially when it goes home to the parents. So as of right now, our summaries that go home, the progress reports, are somewhat integrated and it all goes home at once. In addition to that, we're working to start using electronic health records. And once that is in place, which should be fairly soon, within the next year, we are going to work to integrate client information into one main chart rather than separating by discipline. We are also constantly revising our processes. We're revising grading forms, especially as IPE becomes more of a focus as required by ASHA and other agencies. We are working to integrate specific competencies into how our students are assessed and the experiences that they get. And we are also working to better align OT documentation with the SLP timeline and expectations. So as we move forward, the SLP model that we've established, that was established many years ago, the OT is, integrating into that model, and we are better aligned. So in terms of documentation and grading, it's an ongoing process as well. And now I'm going to turn it over to Iona Johnson, who will talk to you about training and preparing our students.
Thank you, Lisa. My name is Iona Johnson, and I will be talking to you about IPE and students. So one of the things that we run into is when students are coming with different abilities across the disciplines and with different expectations. So how do we address that? That's what we'll take a look at next. So I put my challenges on one slide. I'm the positive thinker here. And I put my solutions on 3 slides, so I just have to show off a little bit. So the challenges that we find are that students are coming to us at different levels of knowledge and experience. So you've heard about the OT students who might be level 1, level 2, level 3, level 4 students even who may have gone off campus and had some extensive experience out in the community and then coming back on campus. We have our students who may be in the clinic for the very first time. They've never worked with an adult. And then we have our students who may have been there for it might be their 3rd semester because it might be the summer of their first year. Let me just backtrack and say I work with the WISH program, which is Wellness in Stroke and Head Injury. Most of our clients are adult stroke survivors, and we're doing a social communication group with OT and speech, and then they also have a wellness component where they go down into the gym, and sometimes our students are also involved there in terms of facilitating communication. So we have 3 disciplines that are working together. So when we're talking about these different disciplines, another thing that comes up is sometimes that the students are using different lingo. I'll go back to the other point in a second. So they're coming from different disciplines and we're using different lingo. So one example that sticks out is the OT supervisor talks about grading a task, and she'll say to the students, well, what about grading the task for this client? So my speech students are thinking grade A, B, C, and the OT students know she's talking about adjusting that level. But now my speech students know that too. But sometimes the lingo is different, and sometimes there's a barrier with that. Also, because our students are sometimes brand new, they may be unsure of their own identity and role. So what do I do as a speech language pathologist, particularly when there are other disciplines involved? How is my role carved out? What am I allowed to do or not do? And again, also with the identity for the OT students as well, especially for some of those who may have had quite a bit of experience under their belts, that they might be a little more assertive with our students because they, of their own experiences. So we do have to keep an eye on that as well. The supervisors themselves might have varying expectations and different styles. And I think across all of the programs, obviously, we see that. So that needs to be a good fit as well, or make it a good fit so that we present a unified front with our students. Also, how will supervision occur across disciplines? Because we have a stroke survivor who has some balance issues, and as we're doing social communication and moving from one place to another, my SLP students need to know also how to guard that client, how to give cues or assistance to make sure that that client is safe. And so the way that the OT supervisor interacts with my students is important, and the way that I interact with the OT and exercise students is important as well in terms of how to facilitate communication and cognitive strategies. So that can be a challenge, again, if we're not all on the same page. We also started out with not having a working model. We knew that we wanted to do this. We didn't know exactly how it would look. And as you've heard from some of the other challenges before, we've also had a lot of changes with who's actually there, like who are the players in the room. So the first semester that we did WISH, we had different supervisors on different days from OT, and we also had different OT students on different days. One semester, because my schedule was a little mixed up, we had 2 speech supervisors as well on different days. So having a working model and figuring out who's doing what is important, and then also how we are facilitating and creating goals for the client. Because I think one thing that really is nice is that being able to have some shared ownership in that. Also, the word ownership comes up because our clients are sometimes, we'll have students who have a perceived ownership, like this person really has significant aphasia, so this is my student, I'm assigned to them, Mrs. Johnson, and I have to look out for them, which is a good thing. But then also making sure that the OT student doesn't completely shy away, but making sure that we can create that balance. Same thing with someone who might have more motor involvement with the OT student, perhaps feeling more ownership and responsibility. Solutions. So we thought that if we can orient all the students across the disciplines, that would be helpful. So at least everyone has the same foundation, the same basic foundation. And to make sure that all of the disciplines are trainers and all of the students from all of the disciplines are there. So this really helps to create sort of a level playing field with basic techniques. One example is making sure that everybody knows how to communicate with someone who has aphasia, how to facilitate communication, to make sure that any material that's presented is aphasia friendly, whether it's a PowerPoint or whether it's written information. So across the disciplines, not just the speech student, but the OT student and exercise as well. Making sure that the students understand, what the philosophy is for IPE, and that's included in our orientation. And it works, this co-orientation works really well when it works, when all of the disciplines are there and involved. But again, we've had some scheduling issues, and really taking the time to adequately train the way that we would like. We sort of really have to hit the ground running, so there's not a whole lot of time to do that, but it is beneficial, and that's something that we definitely want to continue to do. Another solution is having team meetings and rounds so that we can discuss all of the clients together to assess progress as well as problems, to have group planning. And also the group planning also allows for some debriefing. What was that activity like? Did it work? What was, what should we do differently the next time? What do we need to consider? Which client wasn't involved in or didn't like? Well, we have some clients who don't like, a lot of things. But how do we do, what do we do when the client is not involved in the group activity? So just that shared experience. So we do get a lot of benefit from that because it really does facilitate across the disciplines. The students know what to expect, and they all have some guidance as to what to do if. In reality, we've been pretty fortunate in our program because now we have one OT supervisor, one speech pathology supervisor. We run WISH, and we do also have a consistent person in exercise. And they may or may not have a student intern working with the group, so that does change a bit. But in reality, is there shared commitment? It really should be. Again, we're pretty fortunate in that, but that could be an issue. So this picture is of my co-worker and colleague OT, Nancy, and I, and it was 70s versus 90s challenge day, and our students created a wonderful session. And so I thought this was good to talk about supervisor communication. So we really need to make sure that the supervisors are communicating and on the same page. I can't say that, any number of times, but that is really what's important when we're talking about interprofessional work that we do. To make sure that we present a unified front, that we're not, bickering or having conflict in front of the students, but that they know what to expect and what to expect from us. Know that my students are comfortable going to the OT supervisor and vice versa for guidance in certain areas, and so that we have a unified approach. And in reality, it really is working well for us, but it certainly can have some issues, and early on within our program it was, in terms of the professional role. If somebody feels that their identity is challenged, or is somebody, really being so assertive that they're not allowing room for the other person. And it really is safer and easier to stay in our own silos. That's the way we were taught back in the day, right? But this is a whole new world. So I always say to my students, when we work across disciplines, we can really learn from the other person and they can really learn from us, but the client is the one who can get the benefit. So, okay, I think that's all for me. And now we have Karen Pottish. She is our clinical director, and she'll be talking about administration and funding.
Which thing do I push?
This down arrow.
Okay, perfect. Okay. All right. Okay. Hi there, I'm Karen Pottish, and I'm the director of the Speech and Language Center. So I've been involved in the development, coordination, and supervision in many of the IPE programs. Oops, thank you. In many of the you're the shorter one, right? In many of the IPE programs that we run. So I'm going to talk about administration and funding, who pays for IPE, and who is in charge. So some of the challenges I'm going to talk about have to do with supervision costs, revenue collection, and coordination of the IPE programs. So specifically, we have multiple supervisors who are required to supervise in our IPE programs. And what we found was that not only was the cost increased because of the extra supervisor, but the different departments had different workloads, the way they were calculating different faculty workloads, and they had different compensation formulas, which made it very difficult. Also, in terms of revenue collection, we had issues with setting the fees, how do we do the billing, projecting enrollment so that we would make sure we had enough clients participating, and then also the coordination of these programs. How do we staff these programs? How do we go about accepting clients, developing protocols, schedules, all the documentation things that we talked about, and including the marketing and the and materials. So in terms of the solutions, what we found was the way we addressed having multiple supervisors was we initially increased the program cost, and then we worked very closely with the other departments to standardize the pay structure and the direct versus indirect time that supervisors were being compensated for. And before we started any of our programs, we applied for grant funding, and that helped a lot with the materials we needed for the startup costs. And then we set the fees based on billing one discipline only. And the reason we did that actually was threefold. One was to make it affordable, and also to make sure that the fees were consistent for what we were billing the insurance companies versus what we were billing the self-payers. But also because not all of the children required, or actually all the clients required, all of the same services that we were providing. And so, for example, in our children's therapeutic program, all of those children have speech and language needs, but not all of them have fine motor and sensory motor needs. But conversely, in our sensory motor groups, all the kids have fine motor and sensory motor needs, but not all of them have speech and language needs. So it made it a lot easier to just bill under one discipline. We also divide out the costs and the revenues across the different disciplines. Some of our programs, especially some of our adult programs, we actually determined a set fee so that we were sure we would be able to cover the costs. And we are lucky to have a business office which manages not only the billing and the collections, but also the revenue sharing. The last thing about this is that it's very important for us to know to have a projected client enrollment so that we're sure we have enough clients for our students to be practicing with, and that we're sure that we can count on that revenue. And so what we do is we plan well in advance so that we have a sense of how many clients are going to be in a program. And we also overestimate or over-accept clients often with the expectation that there's going to be some attrition by the time we start the programs. And then the way we handle administration coordination is what we have done at our university is we have designated a primary program coordinator. And in the case of Towson, usually the program coordinator is one of the clinic directors. It certainly doesn't have to be, but that has worked for us at our university. And the program coordinator has a lot of different roles and responsibilities. This is not an exhaustive list of roles and responsibilities, but it would have, many different expectations in terms of planning meetings and orientations, coordinating registration procedures, developing documentation protocol, determining program schedules, space needs, material needs and purchasing materials, coordinating marketing strategies, collaborating with all the disciplines to assess the programs, facilitating programming even between programs. So for example, we run an intergenerational carnival every semester where the adults from the WISH program plan a carnival for our children in the children's therapeutic program. So being able to coordinate all of that. And of course, to establish and maintain a positive environment for collaboration and communication. And now I will have Sharon.
Okay, so I'm going to wrap up this lived lessons from the trenches. Again, as I said at the very beginning, I'm the director of the entire Institute for Wellbeing, which oversees all of the clinical programming. So not just speech and language, but occupational therapy, our wellness center, so forth and so on. And one of the issues we had is, how do you build these bridges to create these clinical programs between multiple academic departments and multiple clinical programs? And especially on our campus, it was really difficult because we did not have a single building for the health professions. So what you see up there now is a map of our campus, and pre-2012, all the red dots were where all the different components of our College of Health Professions were located on campus. And so again, the speech and hearing clinic was in the basement, the dark, dungy basement of one of the oldest buildings on campus. And Karen was our clinic director, and it had been in existence for 40 years. And Karen, year after year after year, kept trying to get these collaborative opportunities going with occupational therapy, but they were all the way on the other side of campus, and we rarely saw the faculty in that program. And so we'd all get together and say, yeah, good idea, great, we'd really like to do this. But making it happen when we were so spread out was really, really difficult to do. So one of our solutions, and I realize this is not a solution for every university, is I call it location, location, location. Just like real estate, this is our new building that opened in 2012. And the red dots you see there, my office is the one to the furthest right on the picture. And all of our center directors have the offices right in a row on the same floor of the building. Now, we are located separately from the academic departments. The academic departments are still back on our main campus. They're still spread out across multiple buildings. But the director of the OT Center is 2 offices away from the director of the Speech and Language Center. And the director of the Hussman Center for Adults with Autism is 1 office away from that. So I can be meeting with the center director, and they can say, I've got a great idea for doing thus and so, and we have students coming in, and wouldn't it be great if we could do this next semester? And I can go grab Karen and say, hey, Jackie has a great idea. Come in here for a minute. Let's talk about it. And what used to take months and months and months for us to plan and figure out how to do, we can sometimes within an hour come to an agreement because we're located near each other. We see each other every day. We communicate with each other. So again, I know this isn't possible on every campus, but as much as you can, that really has made a huge difference in facilitating these collaborative programs for us. Also realize a lot of what we talked about today was our collaborations with occupational therapy and how difficult we found it because prior to this building opening, they had never run an occupational therapy center. All of their placements were off campus. So they don't have the 40-year history that our department has. And even though we've had difficulty getting them to come around, we have individually made strides. So Jackie Wilson is the director of the Occupational Therapy Center. That's her in the background there. And she even herself, when I said we were coming here to give this presentation, she said, if we OTs just used the speech and language model, we would save ourselves a lot of headaches. But she's a voice of one within her department. And just like speech and language center directors can't always have full sway with the speech language academic sides of the departments in terms of what's happening, she can't have full sway with the academic side of the OT department. So little by little, we're making progress. She's 100% on board that OT should just be doing it the way we do it, and then we would have wonderful collaborative programs. So gradually we're getting there. One of the other things that we did before when this new building opened in 2012, and our dean at the time was the one who realized we needed to make this happen, is basically creating the position that I am in, which is the director of the Institute for Wellbeing. I was the former department chair in the ASLD department. I had already given my notice that I was stepping down in a year from that job, and then this building started to come into being. And so she asked me to step in and be the director, and she made it an equivalent position to being a department chair in that I report directly to the dean of the college, and I attend all of the leadership meetings that all of the department chairs attend. So that's given me a level playing field that I can sometimes go to the dean and go, we'd really like to do this, but I can't budge with this department. They're really wanting to be inflexible in terms of how they're doing this. And so then sometimes the dean can pull in the department chair and the center director, and we can come to a decision as to how we might do things differently. I have direct oversight of all of the center directors, so the Occupational Therapy Center director reports to her department chair, but also reports to me, and I'm involved in hiring and performance evaluations of those center directors. And so I'd strongly recommend universities that really want to set up these collaborative programs within the on-campus part of the university sort of consider this kind of administrative model. The other thing we did in creating my position is the Wellness Center existed before our new building, and they had their little budget. The Speech Language Hearing Center existed before our new building, and they had their budget. Our Hussman Center for Adults with Autism had started before we moved into the new building, and they had their budget, and each fiefdom was guarded and controlled by a different department. And so one of the things that we did to help bridge the divide in pulling us all together is I have overall budget authority now for all of the center budgets, and I have control of those budgets, and the departments actually do not. So we function in terms of our centers as one giant budget for the clinical programming that we do, and that gives us the flexibility. Just like any healthcare center, you have programs that bring in more revenues and programs that are just getting started that bring in less, and we can use that leverage to start new programs and have them float for a while until we have enough clients in the program to make things roll. It also takes some of the pressure off some of the programs. Like when we do interprofessional education programs, they cost more money because we have more supervisors involved. But because we're bringing in revenue from all of the different programs that we have, and we have things that don't involve multiple supervisors, we're able to basically make it all cost out at the end of the year. And so we are doing a lot. Last year, we had almost 4,000 persons from the greater Baltimore area come to the Institute for Wellbeing for Services, and they visited over 22,000 times for the different programs and services that we offer. And we're doing a lot for our students. So last year we had over 1,000 students come to the Institute for Wellbeing for some sort of clinical training. Now some of that's observation, some of that's being there for 1 or 2 weeks, some of that's being there every day for an entire semester. And they completed over 27,000 hours of clinical training in our facility. And this is just to show, since the building opened, what our growth has been. This is student practicum, internship, and observation hours. The different colors are the different disciplines that are involved up at the Institute for Wellbeing. And you can see that we've almost doubled the amount of on-campus practicum hours that we're offering for our different students. And speech and language is pink at the bottom of the chart. And then occupational therapy that we've been talking a lot about today is the blue in the middle of the chart. And so that is our program, and that's how we're still sort of muddling through. And it has been a muddle over these 4 years, but each year we get a little bit better than the year before. And now we're open for any questions that you might have. So our audience, those of you who came in late, we have an audience of a lot of our students. And then I think there's 3 of you who are not affiliated with Towson University, so welcome.